Bioethics 2.0, Podcast Episode 11, Treatment Refusals. Like many of the ethical issues you will encounter, treatment refusals derives from the ethical underpinnings of respecting people and their autonomous choices. So if you possess the right to consent to something, and you are capacitated, the corollary is you also have the right to refuse. Simple as that. Therefore, at the end of this podcast, I want you to know that there are valid reasons for patients to refuse treatment. There are also good reasons clinicians have to refrain from treating their patients. It is important to understand the rationale and the reasoning behind both of these issues. Treatment refusals. Technological terrorism.
Modern healthcare has reached the stage where we can sustain life indefinitely, and in some cases, artificially sustain people on life support can represent a form of technological terrorism. Some phrase this technological terrorism as, quote, torturing people into living. If you have seen or provided care for patients in the intensive care unit, you know some have or will have poor outcomes. Yet in many instances, the guiding ethic in healthcare, beneficence, where we hope to positively benefit patients, takes a front seat to non-maleficence, the duty we have not to cause additional harm or burdens. In many of these cases, we should move from an ethic of life-saving or life-preserving to an ethic of providing comfort care so that the patient's dignity can be maintained.
What about religious values?
Cultural and religious values come into play quite frequently in healthcare. The classic example is as follows. If you have a capacitated patient and they have an adherence to established religious teachings, they may say on the basis of that belief that they would like to refuse treatment. This might be a case where you might not agree personally or religiously with what the patient is doing, but it's not your purview to say, I have all the knowledge, you can't refuse. What we say is, I have the scientific knowledge, I know this will be beneficial to you, but the patient brings his or her moral standards and religious upbringing all to the table when making a decision. Therefore, if the patient is capacitated, clinicians have no choice but to respect their decisions. It is not up to clinicians to evaluate the validity or rationality of a patient's beliefs when religion is invoked as the basis for refusing treatment. If we know or have very good evidence that they are, say, a Christian Scientist or a Jehovah's Witness, and they can articulate what those beliefs are, and we know they do this on a consistent basis, and we have talked to them and they know the consequences of their decisions. If they are capacitated, they have the ability to make decisions on the basis of their religious beliefs. It is different, though, when they are demanding treatment. That is not an ethically appropriate situation. The subjective nature of belief.
So basically, what it all boils down to is subjectivity. This is one of the things we discussed in a previous podcast regarding what we can feel, touch, or prove. This is definitely one of the things that is subjective. If I were to ask you to prove your religious beliefs, you would look at me confused, because that's not what you do. We don't go around proving those things. They are leaps of faith, and we allow people to make those judgments. You may not say, we think your religious belief is irrational, and therefore we are going to call you incapacitated. That's just not right. And if you ever see that done, that is an example of the outcome standard. Overriding someone's ability to make a decision just because you disagree with their religious preferences. And as we said, the wrong decision from the perspective of a clinician is the patient's right.
Refusals by incapacitated patients.
Incapacitated patients, by the same reasoning that they can't accept treatment, also can't refuse it. We have to go to the surrogate decision maker. So if someone who lacks information, someone who is acting on misunderstanding or delusions, we must go to the surrogate decision maker to get consent. That consent or refusal must be based on what this patient would have wanted in the right state of mind. Value conflicts.
Now, there may be times when all of these things are in conflict. What do? The decisions need to be made such that they are reflecting coherent values that the patient would have had. This is especially true if you're dealing with surrogate decision makers. You don't want the surrogate to be projecting their values upon what the patient's decision might have been. It has to be an authentic choice the patient would have made had they been able to make it for themselves. For instance, you would hate to have a situation where there's an adult child who is a Jehovah's Witness, and they're refusing blood transfusion for their parent when you know for a fact that the parent is not a Jehovah's Witness. This is in fact unethical. you probably need to take that particular kind of surrogate decision-making situation to court because they're not acting in a fashion that the patient would have wanted.
Duties of patients when refusing treatment.
So there are duties that pertain to patients. When a patient is capacitated and they make a refusal, it is up to them to make the reason very clear. So a patient may actually refuse treatment, but the clinician has to ask why. And if it's valid, you say, okay, I accept that reason. Overriding patient treatment refusals.
There are some instances when it is ethically and legally appropriate to override a refusal. These should be in life-threatening situations where the patient is incapacitated and we can't get a hold of a surrogate and don't know if there's an advance directive. We assume that most people, if they were to suddenly die in front of us, would want to be resuscitated, especially if we don't know what they would have wanted. And there have been some cases in transfusion of minors that we found out afterwards that this person was Jehovah's Witness, but we just didn't know. It wasn't like that fact was tattooed onto them. Sometimes there are lives at stake. You might have a pregnant woman who is carrying a full-term fetus, and let's say the woman says to you, I have this vacation I want to go on. I know I have preeclampsia, but I really should be fine. You can respond, no. You really have terrible blood pressure. The danger is great to both you and your future child. We're going to order you not to go on your vacation, that you undergo bed rest. So in these kinds of cases where the refusal has very serious consequences for a person who happens to be dependent on the patient, such as a single mother or father or adult child, or someone who has elder care responsibilities, these might be situations where you might think about overriding the refusal, but you have to be very careful in doing so.
When deciding what standards should guide you as to when to challenge a patient's decision on treatment, there is no expert consensus. Just realize that in general, it all hinges on capacity of the patient. If you have questions about capacity, that is where it's at. So if you have a clinician who raises a question of the patient's mental state in the face of a refusal, you should ask them what they would do if the patient had accepted treatment. This is the conundrum that we encounter with capacity. This is an example of the outcome standard at its worst. So if you're a patient incapacitated and you make a decision that the clinician disagrees with, and then they try to declare you incapacitated just because they don't agree with it, we know that that is unethical. There are also 3 reasons why a clinician can refuse to treat a patient. The first is when it is to benefit their patients. That is, when it's not in their patient's best medical interest to continue with treatment. The physician can say, I am sorry, but I won't treat you. The physician can also make the decision whenever it is against their own moral values or consciences. So let's say that you're an OB/GYN provider and a woman comes to you and wants an elective termination. You can say, I am sorry, but that is not a service that I can provide based on my professional integrity and conscience, but here are people that you can go to in order to receive that service. It would be patient abandonment just to say, sorry, but I can't help you. Lastly, there can be circumstances where to meet the interests of larger numbers of other patients or interests of the greater society, you must refuse to treat. Excellent example here is organ transplantation. So we have scarce organs, and another great example is the H1N1 vaccine, where there are certain prioritized groups. You can refuse treatment to people who are not in those prioritized groups. The bioethics literature acknowledges at least 3 senses of futility which can be used to justify refusal to treat a patient. One of the reasons a clinician might refuse to treat a patient is because it is medically futile. It simply has no medical benefit to you. A great example of this is when doctors prescribe antibiotics to hypochondriacs or other people who are not really sick, just to appease their patients. Based on the grounds of medical futility, they can say, I won't treat you because I believe this action is not beneficial. There is also quantitative futility. The likelihood of success of a treatment is extremely remote. The example that we like to use here is when doing CPR for a severely debilitated, imminently dying patient. That might not be something you even offer, and some people have severe problems with that stance. The other, qualitative futility, involves a more subjective judgment by the clinicians. They say that we have done our cost-benefit analysis, and on these terms, we think the burdens outweigh the benefits, and it's not something we would like to do. In order to be justified, such a determination must be based on peer-reviewed and published evidence or years of clinical experience and judgment. Also, it is important to remember that we would never withdraw care, only treatment. That is very important. Don't ever use the word withdraw care. Lots of people use it, and it's probably in the vernacular, but for me, that would be scary. So you never abandon the patient. You always help with the spiritual or existential things to care for a patient. Maybe we give them ice chips or a glycerin swab to make sure their skin is well cared for. Those things are basic care things. And as we said before, if a clinician doesn't refuse to render treatment, they can abandon the patient. They have to say, I can't do X, Y, or Z, but let me show you where you can get that. Let me show you or refer you to get what you need.